Hi, I'm Dr. Harch, and this is the talk I just gave for the American College of Hyperbaric Medicine's webinar on COVID-19 and hyperbaric oxygen, what we know and what we don't know. Okay, I'm going to talk about the science of COVID-19 infection and the application of hyperbaric oxygen. What do we know about coronavirus? It's an RNA virus, primarily infects humans, but it also infects animals. And it's similar to two very serious coronavirus infections in the last 2 decades. The SARS virus also originated in China, and the MERS virus, the Middle East Respiratory Syndrome virus, which started in the Middle East. And the big point here, though, is that coronavirus, COVID-19, is very similar clinically to the Spanish flu pandemic 102 years ago. It's highly infectious. Comorbidities are important. In fact, obesity-related disease and the elderly seem to be most at risk. Incubation time is about 5 to 6 days, and then there's an infectious period of maybe 48 hours. People have symptoms of fever, cough, kind of malaise, not feeling well, shortness of breath. 40% of people have mild disease, 40% is more moderate, and then the other 20% are pretty severely ill. Of those, 3 to 5% have the acute respiratory distress syndrome, which is the major problem with this illness. Usually by day 7 is when clinical deterioration occurs. In our experience here in New Orleans, patients present to the emergency department, are put on oxygen, admitted to the hospital, and then they've got about a 48-hour period where they either stabilize or deteriorate. Once they deteriorate to a non-rebreather mask, they've got about 12 hours before they need to be intubated. And it's during this period of time where intervention has to occur with hyperbaric oxygen or before. Death on average is about 7 days after ICU admit in the one Chinese study. Laboratory data, what do we find? At least the organs involved, ARDS is in 67%. Of course, lung involvement in all of them. But the kidneys, the heart, and the liver in about 1/3 of the patients are also involved. Blood work shows lymphocyte counts, part of our white blood cell differential, is decreased, and the percent of them is decreased. Liver has decreased function. You can measure that in the blood. And there's an increase in D-dimer and LDH. But the big finding is inflammation, both systemic and in the lungs. And of course, on chest X-ray and CT, very abnormal with bilateral ground glass opacities, or infiltrates, as they're called. When we look at autopsy data, what we see is inflammation, mostly in the lungs, but also systemic inflammation. So the clinical situation in COVID-19 is one of a pneumonitis, meaning inflammation of the lungs, and a progressive lowering of blood oxygen and accumulation of oxygen debt, which, like all debts, has to be paid. Here's a picture of it. If we look at the normal lung, nice fine honeycomb structure, and the COVID lung with the thickened honeycomb interstitium, and of course all the exudate in the air sacs there, all of it preventing diffusion of oxygen. Here's a 4-day progression of chest X-ray in a Chinese patient showing the developing acute respiratory distress syndrome. Here's a quick slide from the latest WHO situation report as of May 5th, 2020, showing that worldwide infection is not abating. Okay, hyperbaric oxygen, what is it? It's a combination drug of increased oxygen and hydrostatic pressure. In the United States, it's kind of restrictive and limited to treatment of wounds. Internationally, a much larger list of diagnoses. But really what it is a treatment for disease pathophysiology. In other words, disease processes. And it is the ultimate treatment for low oxygen level, both systemically and focally in different organs in the body. Main effects are on inflammation, aside from reducing hypoxia or correcting it, and on gene expression. And interestingly, of the massive genes that are affected by hyperbaric oxygen, over 8,101 of them, amongst the largest groups of genes turned on are the anti-inflammatory genes, and amongst the largest groups turned off are the pro-inflammatory genes. Well, here's the list in the United States that is approved, if you will, for reimbursement, the typically reimbursed list. And you can see they're all wound indications. And the additional ones, what I've done is group the infectious ones at the end here, showing that even the infection indications are types of wounds. All right, So how does our lung oxygenate? It does so by one of the universal gas laws, Henry's law. And if you look at this and the gas that is in the air sac in the lung, oxygen, red, carbon dioxide, blue, the oxygen has to diffuse through the wall of the air sac and then into the white interstitium of that honeycomb tissue of the lungs, through the wall of the blood vessel, into the liquid of the blood vessel, and finally into the liquid cytoplasm of each red blood cell. And as the blood passes by, it gives up its carbon dioxide, acquires oxygen, and becomes pink. Well, that's a normal lung. And what Henry's law says that breathing air, 21% oxygen, we have enough oxygen in our lungs to get into the blood and suffice to keep us running. If we put ourselves on 100% oxygen, you have a lot more oxygen in the lungs and the blood. But what happens in coronavirus infection? That's the lung. And so the oxygen now has to diffuse through all of this to get to the tiny little blood vessels that are spread throughout the air sacs. So what happens? In the hospital, the coronavirus patients are 100% non-rebreather mask. They barely have enough oxygen, or they don't. And in fact, what we're doing with hyperbaric oxygen with the coronavirus is we're just extending Henry's law. And we're now going beyond the limit of atmospheric pressure to increased pressure to increase the amount of oxygen. So here it is in a chamber at 1.6 atmospheres, much more oxygen in the lungs, much more ends up in the blood. So essentially what we are doing is we're treating the cumulative oxygen debt in the coronavirus patient, reversing that. We're having anti-inflammatory effects, powerful effects, especially in the lungs. And then there's a daily permanent improvement, which the Chinese data shows. And the one thing we don't have, though, is we don't know that there is any antiviral effect of hyperbaric oxygen. The net effect, however, is that we're tiding the patient over the critical part of the illness till their defense mechanisms gain the upper hand and the virus, like all viruses, burns itself out. Or in the lesser ill patients, what we're doing is preventing them from deteriorating with a daily hyperbaric treatment. The net result is an improvement and a prevention from going on the ventilator.